And I'd like to invite Dr. Aya Shohat-Tal, who will speak about the potential diagnostic importance of conversion dynamics of DHEA to testosterone. Dr. Shohat-Tal is a postdoctoral associate with the Department of Obstetrics and Gynecology and Reproductive Sciences at Yale School of Medicine in New Haven, Connecticut, and is an assistant visiting scientist with the Center for Human Reproduction right here in New York. Welcome.
Thank you. The topic of my... first I would like to thank the organizers and also Dr. Gleicher for giving me the opportunity to speak today and give my spiel. So I'm going to talk about the potential diagnostic importance of conversion dynamics of DHEA to testosterone. And I'm going to touch upon the controversy surrounding the efficacy of DHEA for women with diminished ovarian reserve. But specifically, I would discuss the trials that perhaps can better resolve the controversy and better select a patient population who might better benefit from DHEA supplementation and identify genetic or hormonal or metabolic predispositions that prevent the apparent efficacy of DHEA from coming to the surface, and also present some alternative treatments. I have no conflict of interest to declare. So approximately 1/3 of IVF clinicians worldwide use DHEA to supplement stimulation protocols in women with poor ovarian response. Now, this was the statistic in 2012. Today it has increased. So the question is, how come DHEA use is on the rise despite the controversy? And it probably has to do with in vivo and in vitro studies demonstrating the increased AMH levels, FSH receptor density, increased ovarian steroidogenesis, prevention of granulosa cell apoptosis, and the evidence suggesting that it increases pregnancy rates. Now, DHEA is also an androgen precursor, but it is not a potent androgen like testosterone or DHT, so that it doesn't have the side effects or the virilizing side effects associated with testosterone or DHT use, while at the same time it is not globally metabolized all over the body. It is restricted to tissues that possess the enzymatic machinery required to metabolize DHEA to androgens. So that's what makes it more user-friendly in a sense. So the basis to the controversy that Dr. Gleicher already discussed that surrounds the efficacy of DHEA supplementation is the lack of adequately powered randomized controlled trials that have robust outcomes, such as live birth rates. DHEA is used in different doses in different trials and for different indications and in different populations, and also in different durations. So as Dr. Gleicher mentioned, to reach the gonadotropin responsive stage, it is more optimal to use DHEA for about 4 to 5 months before the start of the cycle. And this is a point that is not commonly attributed to the controversy. However, we noted that it is a major it is a major point that prevents the controversy from being resolved. It is the failure to characterize the androgen status of patients prior to treatment. And this essentially precludes attempts to identify the subgroup that would benefit the most from the intervention. So from now on, I'm going to not talk about the androgen status, but specifically testosterone status, as it is the major downstream metabolite of DHEA. So the role of testosterone in reproduction was already discussed by Dr. Sen, but it is a substrate for estrogen biosynthesis. It stimulates early stages of follicular growth and promotes granulosa and thicker cell proliferation in an androgen receptor-dependent manner. And it increases follicle responsiveness to FSH and or the number of growing preantral and small antral follicles in the ovary. And this effect is also actually androgen receptor dependent, as treatment of mice with the androgen receptor inhibitor flutamide decreases the number of preantral and small antral follicles in the ovary. So where is the testosterone coming from in premenstrual women? So 25% of it is coming from the ovary under the control of luteinizing hormone. It is produced by theca cells in antral follicles. It is produced into the bloodstream, but also into granulosa cells, which metabolize it into estrogen. But you can see that the vast majority is actually coming from the adrenal gland, either directly or indirectly from DHEA and its derivatives. And DHEA is the most abundant steroid in humans. So female testosterone declines with age. It starts declining in the early to late 20s, and by the age of 40, it is about half the amount it was in their 20s. And since DHEA is commonly prescribed for women with diminished ovarian reserve, let's take a moment to discuss the characteristics of DOR. Well, you probably know about it better than me, but it is characterized by abnormally low number of recruited follicles, poor ovarian response to stimulation with gonadotropins, low number of mature oocytes, poor embryo quality, low rates of implantation and pregnancy, and some present with low serum testosterone levels. So in studies on testosterone levels in women with premature ovarian failure, premature ovarian aging, which is defined as abnormally low AMH or abnormally high AMH by age, and in DOR patients, it was shown that women with POF have significantly less testosterone than controls. The same applies for women with premature ovarian aging. And physiological DOR, diminished ovarian reserve, also demonstrated a trend toward lower testosterone levels relative to controls. So then Gleischer's group came up with a rather paradigm-shifting study, I would say, demonstrating, they looked at androgen conversion rates in patients with diminished ovarian reserves that are supplemented for at least 6 weeks with 75 milligrams of DHEA daily. They expressed androgen conversion as the percentage change in total testosterone divided by the percentage change of DHEA from baseline to cycle start. And they demonstrated first that in women older than 38, there is a significantly reduced androgen conversion rate, which is not surprising, as there is a general decline in steroidogenic capacity with age. But they also, more interestingly, demonstrated that in women younger than 38, the pregnancy outcome correlated with the androgen conversion rate, in that women achieving pregnancy had significantly higher androgen conversion rate relative to women who did not achieve a pregnancy outcome. So the conclusions from these early studies demonstrated that the evaluation of androgen conversion upon DHEA supplementation in younger women with DOR may be predictive of their pregnancy chances. Now, I highlighted upon DHEA supplementation because it suggests that DHEA may have a diagnostic role in predicting which women may benefit most from supplementation. And so the question that comes up is, what factors influence the conversion of DHEA to testosterone? And when I first came to CHR, Dr. Gleischer suggested that I look into this question, because it was very interesting in the setting of CHR's staff meetings to sit and see that it seems that most patients who did not achieve a pregnancy outcome were given DHEA, but their testosterone levels did not rise. So the first place to look at in order to answer this question is to look at the metabolic pathway of DHEA to testosterone. Because testosterone ultimately binds the androgen receptor and exerts the ovarian effect. So I'm going to specifically talk about two genes in this pathway that have single nucleotide polymorphisms that are associated with reduced testosterone levels. Now, these SNPs were investigated in the general population and not specifically in women with infertility. So we propose looking into these SNPs in the context of diminished ovarian reserve and hypoandrogenism. I will also discuss two other genes that are not on this slide because they are not in the metabolic pathway, but they are regulators, nonetheless, of serum testosterone levels. So the first gene is SOL2A1, which is a sulfurtransferase, which is highly expressed in the zona reticularis of the adrenal cortex, as well as in the liver and small intestine. And this is where DHEA is first passaged through and metabolized. DHEA sulfurtransferase catalyzes the conjugation reaction. It conjugates a sulfur group. It conjugates a sulfur group to DHEA, creating its sulfated ester, dihydroepiandrosterone sulfate. Now, DHEAS is considered the storage form of DHEA in that it is more stable, and it has a longer half-life, about 20 times the half-life of DHEA, a slower clearance rate, and consequently, DHEAS is found is about 100 times higher in circulation than DHEA. Now, once DHEAS enters the cell, it is quickly metabolized back into DHEA upon metabolic demand, of course, by steroid sulfatases. Now, it was shown in mouse models that SOL2A1 is negatively regulated at the level of mRNA, enzymatic activity, and also at the level of the product, DHEAS, by acute phase inflammatory response and pro-inflammatory cytokines, such as tumor necrosis factor alpha. Now, many of you probably know this cytokine from its implication in recurrent pregnancy losses. Now, there are two single nucleotide polymorphisms that are found exclusively in African Americans, and in which transfection of constructs expressing these SNPs into kidney fibroblast cells resulted in reduced expression of the gene, reduced activity, as well as reduced DHEAS production. Now, it is interesting that these SNPs are only found in African American women, as it is known as this may be a contributing factor to their reduced fertility and racial disparities in IVF cycle outcomes. Now, the role for DHEA sulfonation in pregnancy outcome was demonstrated by Weghofer and colleagues in women with POA that are supplemented with DHEA. So she showed that while DHEA levels after supplementations is not differentially, doesn't have an effect on clinical pregnancy rates, the DHEAS levels are significantly higher in women that achieve clinical pregnancy versus those that do not. So this was a major point. And the next gene that also has effects on testosterone levels is CYP19A1, which codes for aromatase. And aromatase converts testosterone and androstenedione to estradiol and estrogen, respectively. Here, SNPs associated with aromatase hyperactivity and specifically reduced testosterone levels are those that are also significantly increased in African American women and also in women with breast cancer or with BRCA1 mutations. So again, suggesting that these SNPs may be a contributing factor to their to the decreased fertility in these populations. Now, aromatase inhibition with letrozole or other short-lived aromatase inhibitors for a very brief period of the stimulation cycle was shown to significantly increase follicular fluid, total testosterone, and androstenedione in poor responders, concomitant with increased AMH levels, oocyte yield, and embryo implantation rates. Now, we know that aromatase inhibition can work in two ways. So it by decreasing the amount of estrogen produced, it reduces the negative feedback and increasing gonadotrophin sensitivity. At the same time, it increases the intrafollicular androgen milieu, and that allows for, and that increases FSH receptor expression and also responsiveness, as Dr. Sen demonstrated. The next hormone, which is not in the metabolic pathway, is sex hormone binding globulin. It is known that approximately 10 to 15% of intracellular androgens diffuse to the extracellular compartment where they are bound to SHBG. And those hormone fractions not bound by SHBG are considered to be bioavailable in that they can bind to and activate hormone receptors in target cells. Again, African American women have higher levels of SHBG and lower free testosterone levels than white women. And hyperthyroidism is also associated with elevated SHBG and lower free testosterone levels. And finally, the Fragile X mental retardation gene that I will expound about tomorrow in my morning talk has a 5' untranslated region that has variable number of CGG repeats. And CGG repeats 55 to 200 is associated with Fragile X primary ovarian insufficiency. Now, again, Glaisher's group demonstrated, that in women with DOR, carriage of at least one allele with less than 26 CGG repeats is actually associated with reduced androgen conversion rate relative to other genotype groups following DHEA supplementation. So to conclude, the efficacy of DHEA treatment in patients with diminished ovarian reserve may depend on their baseline androgen status, with the caveat that genetic variants, age, ethnicity, and comorbidities can affect the metabolism of DHEA to T, and this may account for the variation in response to treatment. And these women may instead benefit more from direct testosterone administration. Now, the SNPs that I discussed so far were only examined in the general population, and as I mentioned before, looking at them in the context of infertility and DOR may prove advantageous for treatment purposes. And DHEA emerges as having a diagnostic role, such that hormonal profiles following DHEA supplementation may point to genes or pathways that have aberrant function, allowing selection of more targeted treatments. And I would like to conclude actually with a last slide that goes back to the issue of the controversy surrounding DHEA supplementation. So we would like to propose a better, a more improved study design in which first the population of patients who would most likely benefit from DHEA is being studied. And we think that is the population of DOR, POA, and POF that have low baseline testosterone levels. And the next point in this study design, if you will, is to perform successive stratifications of the patients depending on their response to DHEA treatment. So, for example, upon DHEA supplementation, if testosterone levels significantly increase, that would be one strata. And next, if these levels fail to increase following administration, DHEA-S levels may be assessed. If these are resistant to increase, it may point to DHEA sulfonation failure, in which case clinicians may want to evaluate TNA alpha levels. If these are elevated, they may consider treatment with TNF alpha inhibitors and assess IVF outcomes. If TNF alpha levels are at normal range, the sulfonation failure may be traced to the single nucleotide polymorphisms I discussed, or to an age-related decline in the function of the zona reticularis. So it may, and again, these polymorphisms are actually prevalent in the African American population. If DHEAS levels increase, but testosterone is not elevated, evaluation of the estradiol to testosterone levels may be merited. If it is elevated, it may point to those polymorphisms we discussed, or BRCA or to BRCA1 mutation carriers, in which case treatment with aromatase inhibitors may be considered. And if still all these levels are normal, thyroxine or SHBG levels may want to be looked into. If they are elevated, treatment with antithyroid drugs may change those IVF outcomes. And if these are still normal, then the last resort would be to consider direct testosterone administration. So you see that in this example of a study design, the factors that may be confounding to assessment of DHEA efficacy are accounted for, and it's just one way of designing studies that help resolve the controversy. So I would like to thank the Center for Human Reproduction, Dr. Barad, Dr. Kushner, and Dr. Gleicher for his mentorship. Thank you.
Thank you very much. We have barely time for one question, and then we'll break for a coffee break and reconvene at 4:15. I will arbitrarily select the gentleman in the third row. Apologies to those who will probably have a discussion with you outside.
Thank you. Is it logical to adjust the DHEA dosage according to the baseline androgen levels, or is it better to use a fixed dosage to all patients?
I would say it is best to use a fixed dosage, just because due to all these factors that can change the varying metabolism that is completely individual. It would be best to just start with a dosage that is known to work, that has been shown in some studies to work, and then adjust it if because the dosages that were used were dosages that do not cause testosterone levels to become super physiological, and were shown to have very little side effects, if any. And for the sake of not wasting the patient's time, I would say that using a dosage that is known to work is best.
Thank you very much.